everyone, my name is Shanaz and I welcome you all to my channel Nurses, the Heart of Healthcare. If you are preparing for any of your nursing competitive exams or for a nursing interview for national or for the international hospitals, maybe to obtain your MOH license or to obtain your DHA license or for any of the foreign countries, then this video is going to be of great help to you, because the main intention of this video is to help you guys prepare to put your best foot forward during every stage of your nursing interview process. Guys, please remember to approach your interview as if you're having a professional discussion with a friend. Stay focused and on point. The type of questions that you're going to face in a nursing interview is not always theory based. An interviewer may ask you 3 different categories of questions in a nursing interview. The first category is they may ask you some general questions, okay, that is regarding your strengths, your weaknesses, your work history, your relationship with the co-workers, okay, about yourself, to get an insight of what kind of a person you are, okay. Then the next category is they may ask you theory based questions. These are direct questions like what is stroke or what is an MI, what are the causes of MI, okay, what are the articles that you require for so and so procedure, what are the complications of this procedure, what is the complication of this disease. These are direct theory based questions which are easy to answer. Then the third category of questions that you may come across are situational questions, scenario based questions, okay. The interviewer is asking you situational questions to gain an access, or what we say, to gain an insight into your thought process, your problem solving abilities, your communication skills, okay. So using your knowledge, using your experience, using your critical thinking skills, you have to answer these questions very smartly. Scenario based questions are the most challenging questions in an interview, okay. They are very tricky, simple if you understand, okay. So listen to the question properly, understand what the interviewer wants to know, and using your knowledge, experience and critical thinking skill, answer them properly, okay. So you have to communicate properly, okay, and answer to the point. Fine. So let's get started. Guys, before moving ahead, a small reminder, I would really appreciate that if you are new to my channel, please subscribe my channel, and if you find my videos helpful, easy to learn and understand, then please like and share my videos. Okay, let us discuss some of the scenario based nursing interview questions and answer, okay. So these question answer session will surely help you to understand, not only to answer the questions that are discussed, but also to how to answer a challenging and a tricky question, okay. So let's get started. The first question is, you have to work closely with a difficult co-worker. How will you handle? How will you build a relationship with this person? See, everyone is not same. We come across different kind of mentalities, different kind of personalities at the workplace, and we have to work as a team for better patient outcome, okay. So you have to answer this question very smartly, and please remember guys that never speak negative about any person, even if you have faced. Never speak negative about any of your colleague, any of your seniors or juniors you have come across, okay. If there was any negativity also, turn it into a positive situation, turn it into a positive thing in your answer, okay. Fine. So how will you answer this question? Working closely with difficult co-workers can be challenging, but it is important to remember that the patient, their family, their care is more important, okay. So putting aside all the differences is essential for the nurses, because not everyone is the same, and patient care, patient is the priority, okay. So patient care, patient satisfaction, patient safety is more important than all our personal differences. Fine. And you can also say that generally I get along well with most of my co-workers because I have a calm attitude and I always offer help to my colleagues. Yes, the person who help others at workplace is, usually a good one. He or she usually will not have much problem with others. Fine. And sometimes you can also say that sometimes we should never discuss some topics which can create an issue, like topics related to religion or politics. These can create some conflicts, so better not to discuss such topics at workplace. Yes. And you can also say that not everyone will become friends at workplace, okay, but working together is a key for the successful care of the patient. Oh yes. Okay, so patient centered care is more important. Okay, so you have to put aside your differences and work as a team for better patient outcome. Okay, so this is how you can answer this question. Then next question, you receive a patient in the ER with complaints of retrosternal chest pain, shortness of breath on exertion and diaphoresis and one episode of vomiting. What will you do? The interviewer wants to know how will you deal with a patient who came with chest pain in an emergency department. What will be your priority? There are many things to be done, but what will be your priority? How will you move ahead? How will you go step by step to deal with this patient? Okay, so how will you answer this question? The first thing that you should do is calm your patient and make him lie down on the trolley and connect the patient to the cardiac monitor immediately. Okay, and get an 12 lead ECG. Okay, immediately you have to do an ECG. Okay, obviously when you are in a triage you will not be alone, you will have another person with you, so you can take the help of that person and the other person can check the blood pressure, GRBS simultaneously. Okay, and obviously the doctors will be obtaining the history from the patient and or from the patient's family. The history can be obtained like from when he is having the pain, he or she, from when they are having the pain, and is the pain radiating, to which part it is radiating. Okay, and how is the shortness of breath, if he is having more shortness of breath. Okay, if he is hyperventilating, then you can put the patient on oxygen therapy. Okay, and you should also obtain history regarding their comorbidities, if they are known hypertensive or diabetic or any cardiac history before. And you should also ask them if they have visited any other hospital and what they have done there. Okay, apart from taking an ECG, what they have done there, did they give him or her any medication? So okay, all this history to be collected simultaneously, it has to go hand in hand. Okay, you got an ECG done, then ECG shows that the patient is having an MI. Okay, myocardial infarction. Then immediately, as per the doctor's order, cardiac loading doses can be given to the patient. If the patient has already received cardiac loading doses in the outside hospital where they visited before, it's done. Otherwise, you have to give the cardiac loading dose as advised by the cardiologist or the doctor. Okay, it can differ from unit to unit, but the usual cardiac loading doses that are given to the patient are tablet ecosprin 325 mg and tablet atorva 80 mg and tablet Brilliant or Axer 180 mg. Okay, so it can differ different hospital to hospital, but these are the usual cardiac loading doses that are given. Then after giving this, simultaneously IV access should be obtained. Okay, get an IV access, and you can give pan and Zoffer to the patient. Okay, because the patient is having vomiting, he should not vomit out the cardiac loading doses that you have given. Yes, so you can give pan and Zoffer to the patient. Then if your hospital is having a cath lab facility, then you have to prepare the patient for cath lab. Get a blood sample, okay, and send it for the pre-angio panel, TROP-I2, okay, and you have to put 2 cannulas to the patient, okay, and part preparation to be done. Obtain family consent, okay, you have to obtain the consent for the cath lab, okay, and get all the billings clear. Okay, if the bills are everything is cleared, the patient family agrees, okay, cath lab is done, then you can shift the patient immediately to the cath lab. Okay, if your hospital is not having a cath lab facility, then if the patient has come to the hospital within window period, the window period in ACS is 12 hours, okay, then you can start thrombolytic therapy in the ER itself. If your hospital is not having cath lab facility, okay, then thrombolytic therapy can be started in ER itself. And the window period in ACS is, please remember, it is 12 hours. Okay, from the time the pain started, okay, it is 12 hours. If the patient is in window period, then you will do the thrombolytic therapy. If 12 hours has crossed, the patient is coming after 12 hours, then you will not do thrombolytic therapy. It can cause more damage to the patient if you do thrombolytic therapy after 12 hours. Okay, and door to needle period in ACS, door to needle period is nothing but the time when the patient has come to ER door to the time when thrombolytic therapy is starting. It is 30 minutes. That means within 30 minutes you have to complete all your initial ER assessment, billing, ECG, blood samples to be sent, everything, part preparation, all this to be, it has to finish within 30 minutes and thrombolytic therapy to be started. Okay, so that is door to needle time, which is 30 minutes, and door to balloon time, it is 90 minutes. Okay, that is the time when the patient has come to the ER door to the time when the blocked vessel is opened in cath lab. Okay, so the door to balloon time is 90 minutes. So time is very crucial, guys, when it comes to brain and heart. Okay, the time is very crucial in some conditions, and we need to act fast, we need to act promptly. Okay, so everything has to be done fast and correctly. Okay, so all these things should be finished, and you have to shift the patient to the safe hands so that the process can go ahead. Okay, fine. So this is how we deal with the patient who comes to ER with the chest pain. Fine. Then next question is, if patient's family is dissatisfied with your care, how will you handle them? Oh, this is a common problem. We come across this almost every day. Yes, okay, all days are not good. Some days we receive appreciation, and sometimes we receive, sometimes we receive comments, and sometimes we receive compliments from the patient and the patient family. So it's common. Never get disheartened. Okay, so patient and patient family satisfaction is critical component of quality patient care. Many a times it happens that the patient condition does not improve or deteriorates in spite of the best care provided, and this can be because of the comorbidities or the complications of the condition, or because they came late to the hospital, it was diagnosed late. Okay, because of multiple factors, the patient condition deteriorates or not improving. At that situation, patient and patient family being not happy or being displeased with the healthcare provider, it's a common thing. Okay, but we have to deal politely with it. Okay, so the patient is in pain, they are under physical, mental, emotional and financial stress, and sometimes they may get angry at you, they may be displeased with you, they may not be satisfied with you, they may complain. So in such a situation, communicating with them and comforting them is really important. So what you have to do is, you have to listen to them politely. Listening, this will solve most of the problem. You have to listen to them politely. Don't argue. Please don't argue. Listen to them politely. And how can you can handle the situation? With compassion and kindness. Okay, so first listen to their concern, don't argue with them, and deal with the situation properly. Okay, so patient family is an integral part of the patient care, and building a trusting relationship and acknowledging their concern and solving them accordingly is very important. Okay, so you can solve the situation by being honest, by being transparent, by communicating and keeping them well informed. And if a mistake has been done, then it is always better to apologize. There's no harm in apologizing. Apologize and correct the mistake that was made. Okay, and check out with them that what it is that is making them unhappy, what it is that is that they are not liking, and you can work out them. Okay, so this is how we can deal with difficult family members or those who are not happy with your care. Fine, I hope I answered the question. Fine. Then the next question is, when you receive a verbal order from a physician, what will you do? Can you take verbal medication order or not? In what situation and how? Sure. Let answer. As we all know that verbal medication orders can be accepted only in case of emergency. Okay, otherwise the order has to be returned and then you have to give the medication. Okay, stat orders, it has to be returned and then you have to give the medication accordingly. It has to be written clearly in capital letters, okay, which should include the drug name, the dosage, the route, the time, everything, the date and time, everything. Okay, but in case of emergency, verbal medication orders can be accepted from the physician. For example, CPR is going on. The patient had an arrest, CPR is going on, and the doctor is asking you to give injection adrenaline. Okay, you have to give adrenaline every 3 to 5 minutes in an arrest. In ACS algorithm, if you see, that time you cannot ask the doctor to write it down and then only I will give. No. In case of emergency, medication orders, verbal orders can be accepted. For example, the patient got an SVT, supraventricular tachycardia, and the doctor is asking you to give adenosine. Okay, you have to give it fast to revert the patient. Otherwise, it can complicate. That time you cannot ask the prescriber or the doctor to write it down first, then I will give. No. Verbal orders can be accepted in such an emergency situation. Okay, for example, there is an emergency intubation going on. Okay, you are intubating the patient. Okay, then you have to give at that time sedation, muscle relaxant, yes, and you have to give Fanta, you have to give Vecuronium, you have to give Propofol. Okay, there are so many emergency medications that are required during intubation time. That time you cannot tell the doctor that no, first you note it down, then I will give. So he will remove his surgical gloves and everything, he will stop the intubation. No, it cannot be. So in case of emergency, please remember guys, we can take verbal medication orders. Okay, and later on, once it's done, please make sure, please be back of the prescriber to write it down, to write down the orders, clear orders, and then you sign immediately with the time it was given. Okay, so the verbal medication order is only legal if the prescriber signs the order on the patient drug or fluid chart within 24 hours. Okay, and in case when you are receiving telephonic verbal medication order, please follow read back policy. Okay, I hope you all know what is read back policy. Whenever you receive a telephonic verbal medication order, then what you have to do, you have to note it down. Whatever the order is given, the medication name, dosage, frequency, everything, you have to note it down and read back to the prescriber and confirm before giving it to the patient. Okay, this is called read back policy. This you have to follow it when you are receiving telephonic orders, verbal orders. Okay, so whenever you are receiving the order, you have to record it. Okay, and make sure that within 24 hours it is signed, either what we say, electronic sign or a handwritten sign, but it has to be signed. Okay, so this is for verbal orders. Next question, I hope I answered the question. Next question, give an example of a time you had to interact with a hostile patient and how will you handle the situation and what was the outcome. Okay, so here the interviewer wants to know that if you come across or if you face a hostile patient, how will you deal with him or her. Okay, what will you do? Will you also become hostile, or you will deal with the patient smartly, patiently, and for the better patient outcome? See, unfortunately, hostile patients often are a part of the job. It is important to remember that the patient become hostile because they are in pain, because they are away from the family, because they are in a hospital setting, because they are not able to communicate their need and their wants to us. Okay, the patient and the patient family, they are going through a lot of physical, mental, spiritual, emotional and financial stress when they are in the hospital. Okay, so sometimes they become hostile, sometimes they get angry, sometimes they argue, they shout, they refuse to take the treatment, they refuse to do the things that are said. Okay, that time we have to be patient and deal with the situation smart. We have to make them understand if the patients are having some rights, they do have the responsibilities too. Okay, so we have to follow the patient rights and the patient should follow their responsibilities. Then the care becomes easy. We can get better outcomes. Okay, so I will give you an example of the situation that I came across when I was in triage. Once I was in triage and we received an RTA case, road traffic accident case, four-wheeler versus four-wheeler. Okay, there were 4 people in the car, including the driver, and except the driver, the other 3 people who were sitting in the car got injured, and 3 of them were brought to the emergency. Okay, and I was dealing with this female patient, and she got head injury. We did the dressing, and we got an IV access. We started with the pain medication. We have given her the medication to stop the bleeding, and we started with the IV fluids and everything. And then she told that she wants to go to the washroom. I said her that, ma'am, will provide you a bedpan, because going to the washroom for you is risky at this stage, because you suffered a head injury, you lost a lot of blood, okay, and your blood pressure is on the lower side. If you go to the washroom in this situation, your blood pressure, you may get giddiness and you may fall, and this can complicate your situation. I tried to explain her, but she did not agree. She said that I am a doctor, I am a medical professional myself, and I know all this, I can handle, I want to go. Then I told her, ma'am, if you are a doctor, then it should be very easy for me now. It should be very easy for me to explain you now. You know the situation very well. Okay, that it is very risky for you to go to the washroom now. Yes, I tried to explain her, but she didn't agree. Then what I did, I escalated this matter to the doctor, to the triage doctor. And even she tried to explain her that how risky it is for her to go to the washroom at that point. But still she didn't agree. She said that the bedpans are so dirty and many people use it. I don't feel comfortable. I don't want to use the bedpan. I want to go to the washroom. In spite of explaining, she didn't agree. Then we have to call the transport. We arranged a wheelchair for her so that we can take her to the washroom with 2 transport ladies and with the housekeeping lady. Yeah, we were shifting her from the bed to the trolley, to the wheelchair. And the moment when she sat on the wheelchair, she felt giddy. And she felt giddy, and she kept her hand on the head like this, and I don't know what she felt. She kept quiet for a while, and she said that, I think what you said was right. She told me like that. She said, I think what you were telling was right. I think I cannot handle it. It's better that I agree with what you said. It may not be safe for me to go to the washroom. I better take the bedpan. Then I felt so happy, and immediately, with the help of the transport lady and the housekeeping lady, we shifted her back to the trolley, and we provided her with a bedpan. Okay, so sometimes it happens. Nobody feels comfortable to urinate, to pass urine on the bedpan. Okay, because it is not the routine that we follow, right? It's really uncomfortable. Some people, they feel it's very dirty, and many people use it not comfortable at all. But it is a situation demand. We are not doing it willingly. It's a situation demand, and sometimes we have to follow what is safe for us. Yes, sometimes you have to give priority to your health than your comfort. Yes, okay, going to the washroom and doing it there is more comfortable maybe, okay, but it is risky. You may fall, and you may complicate your condition. So that time you have to look over your comfort level and give importance to your health. Okay, so this was the situation once I faced, and this is how I handle it. Okay, and I really felt very happy that somehow she understood, and she did it there. If she would have gone to the washroom and she fall there, then it would have been very, very bad for us. Yes, okay, so by God grace she understood, and this is how we handle it. Fine. The next question is, if you see flat line on the patient's cardiac monitor, what will you do? Oh, this question I faced in one of my nursing interview in Delhi. Yeah, once I was at Delhi. In one of the nursing interview for the MOH license, I faced this question. It was asked to me, okay, that if you see a flat line on the monitor, cardiac monitor, on your patient's monitor, what will you do immediately? So as we know that flat line or asystole is a cardiac arrest rhythm in which there is no electrical activity of the heart. Yes, but it's not that you see a flat line and immediately you will start the CPR. No. first thing what you will do is, when you see a flat line flashes on the screen, you will check your patient's response. You will tap the patient and you will check, ma'am, are you okay? Sir, are you okay? And you will also check the leads placement, whether the leads are properly placed or not. Sometimes the patient turns this side or that side, or when the patient is profusely sweating, the leads may get disconnected, and then it may show flat line obviously on the monitor. Okay, so you have to check the patient's response and check the leads. If the leads got disconnected, then please connect them properly and monitor the patient. If the leads are proper and there is no response from the patient, okay, the patient is not responding, then what you will do, immediately you will call out for help. You will ask your colleague to get a crash cart, okay, which contains the defib and all the emergency medication, and then your colleague gets the crash cart, ambo and everything. Meanwhile, you will check pulse along with respiration. Look, listen and feel. Okay, the patient is not responding, there is no pulse, no respiration, immediately you will start CPR. Okay, you will start with the compression. Meanwhile, your colleague will get the crash cart. He or she will connect him to the patient to the monitor, to the defib. Okay, they will load, one will load the emergency medication and check for the IV access. If already the IV access is there, check whether it is patent or not. If there is no IV access, please get an IV access first. Okay, meanwhile one will continue the compression. Okay, and one will manage the airway. Okay, so as we know, the ACLS protocol, that we have to give 30:2 compression. Okay, 30 compressions and 2 rescue breaths. Okay, and once the emergency medications arrive, you can give adrenaline, injection adrenaline, 1 mg every 3 to 5 minutes can be given, and you have to follow the ACLS protocol. Okay, so after 2 minutes of CPR, you can check the pulse again. Okay, and you will also check on the defib. If it is non-shockable rhythm still, if still the asystole, then you will continue the CPR. If it is a shockable rhythm, then you will give shock to the patient. Okay, so every 2 minutes you have to check for the pulse. Okay, if there is return of circulation, then you have to act accordingly. Okay, so you have to follow the ACLS protocol. And after 2 minutes, you have to check the pulse and respiration. If the rhythm is shockable, you will give the shock. If the rhythm is not shockable, you will continue with the CPR. Please make sure when you are giving CPR to the patient that your compressions should be hard and fast. Okay, so you have to push fast, you have to push hard. You have 2 inches depth, and rate is 120 compressions you have to give in 1 minute. Okay, so you have to follow the rate and the depth. Okay, and you have to allow adequate recoil of the chest. Okay, avoid hyperventilating the patient and avoid interruption. If you are fatigued, you need to have the backup. The other person should be ready to give the compressions. Okay, obviously when you are giving effective CPR, you will get tired. Okay, so after every after every 2 minutes, after every 5 cycles, you can change the the person who is giving compression can be changed. Okay, so you should have the backup. So these are the things you need to keep in mind. Fine. The next question is, you receive a patient in ER, and during your initial assessment you found that his BP is 180 by 110 mm of mercury. Doctor advised to give TAP Stamlo 10 mg. Available dose is 5 mg, each tablet 5 mg. How will you administer? Okay, so TAP Stamlo, as we know, it is an antihypertensive. Okay, your patient BP is high, 180 by 110 is high. Yes, always remember guys, whenever you're checking the BP and informing it to the doctor, if you find the BP very high or very low, please confirm it, recheck it, confirm it. And in case if the patient is known hypertensive or known cardiac patient, you have to check the BP on both the arms. Okay, before escalating it to the doctor, please check the BP on both the arms. And if you find a difference of more than 20 to 30 mm, 20 mm of mercury between two arms, then there can be a complication. Fine, so you have to escalate the matter to the doctor. So please confirm the BP once again if you find it very high or very low. Okay, and now the doctor has advised to give you Stamlo 10 mg. What is the formula for the tablets? Required dose by stock dose. Okay, required dose by stock dose. The required dose, the dose that doctor has ordered is 10 mg. Stock dose what you have is 5 mg. So 10 divided by 5 is 2. Okay, so you have to give 2 tablets of 5 mg Stamlo to the patient. Okay, and you have given the tablet, that's not enough, you have to monitor the BP. You have to closely monitor the BP. Okay, whether the tablet what you have given is working out or not, or the patient require any other intervention. Okay, so this is how you will calculate. For tablets, the formula is required dose divided by stock dose. Fine. Okay, I hope I answered the question. Guys, I hope you all are listening attentively. Okay, and understanding what is explained. Fine. The next question is, while taking care of a patient with acute gastroenteritis, you notice redness along with pain at the cannula site. What will you do? Okay, so you are taking care of a patient with acute gastroenteritis, and you know that the patient with acute gastroenteritis, they will be receiving antibiotics, they will be receiving fluid therapy and all that. Okay, so IV cannula is very important access for them, and you have noticed pain and redness at the cannula site. So what will you do? What will be your immediate nursing action? So pain and redness at the cannula site, that means the VIP score is 2. What is VIP score, guys? VIP score is visual infusion phlebitis score. VIP stands for visual infusion phlebitis score. Okay, it is 0 to 5. Okay, so if the score is 2, that means it is an early stage of phlebitis. So what you will do? Immediately you will stop the IV fluids or the infusion what was going on. Okay, and what you will do is you will put another cannula. You will resite the cannula. You will get another IV access. You will remove this cannula. Okay, and it's not that the affected hand or that hand, you know, that the patient has to keep it like that only, it will cause swelling. So you can raise the arm. Okay, you can put a pillow or some comfort device below the arm, so that the patient will have, you can elevate the arm so that he will not get swelling. Okay, and you can also provide warm water compress. Okay, warm water compress can be provided, and if the patient is complaining of pain, some topical anti-inflammatory cream can be applied. Okay, so this is how we can handle the situation. Okay, if the patient is having pain and redness at the site of cannula. Okay, immediately you will resite the cannula, you will elevate the arm. Okay, you will remove that cannula, and you can elevate the arm by putting a pillow or some comfort device. You can apply warm water compress and some anti-inflammatory cream also. Okay, and still if the patient is having more pain and all, you can give some anti-inflammatory drugs as per the doctor's order. Okay, fine. I hope I answered the question. The next question is, during your assessment you found that the patient GRBS is 35 mg per dl. What will you do? Hypoglycemia. GRBS 35 mg, that means the patient is severely hypoglycemic. What will you do? You will wait for the doctor, you will go, you will inform the doctor, you will take the doctor's order, then you will act, or you have some decision making power here. Yes, you have the decision making power here. When your patient is having hypoglycemia, and 35 mg is really severe hypoglycemia, and severe hypoglycemia, remember guys, it is a life threatening condition. If you don't give immediate medical treatment to the patient, then you are starving the brain of glucose, and the patient can have seizures, the patient can go into coma, or the patient can die even. Okay, so you have the decision making power of giving 25% dextrose to the patient in this situation. Okay, so whenever you find a patient is having severe hypoglycemia, the GRBS is very low, immediately you can take a decision of getting an IV access, putting an IV access to the patient, putting an IV cannula. If the patient is already having one, then it's well and good. Immediately you can connect 25% dextrose. If the patient is not having an IV access, put an IV access and administer 25% dextrose to the patient, and then you can inform the doctor. You need not wait for the doctor's order to start a 25D. Okay, so this is nursing empowerment. You have this decision making power. When your patient is hypoglycemic, you can administer 25% dextrose to the patient, then recheck GRBS. If still low, then as per the doctor's order, you can give one more 25D or whatever is their order. And if it is okay, then you have to monitor the patient. Okay, so this is what you can do. Guys, remember, whenever the patient is having hypoglycemia, they will have blurred vision, they will have difficulty in concentrating, they cannot think, their speech will be slurred, they will have numbness, they will have drowsiness, and glucose is very important fuel for the brain. We cannot starve the brain of glucose. Okay, so if the patient is having hypoglycemia, act promptly, put an IV access and start 25D without waiting for the doctor's order. After starting, you can inform the doctor. Fine, you can ask the doctor to write it down. You can record everything what has happened, okay, in your nurse's notes, and act accordingly. Fine, I hope I answered the question. Then the next question is, why is it important for the nurse to properly prime IV tubing? Priming. Guys, you know what is priming? Priming is removing the air from the IV set, IV tubing. Okay, whenever we are starting any IV fluids or IV medication for the patient, when we are connecting the IV set to the bottle, okay, IV fluid bottle or whatever the medication bottle, and what we do, we'll fill the tube with the fluid. Okay, we'll gently press the chamber and we'll make sure that it is more than half full. Okay, and we are removing the air from the tubing. That is called priming. Okay, so that we can ensure that no air bubbles are present in the infusion set or in the IV set. Why we are doing this? To prevent air embolism or gas embolism. Okay, if we are not removing the air from the IV set and we are administering air to the patient, it can cause air embolism to the patient, which is very dangerous. These air bubbles, they can travel to the patient's brain, heart, lungs, and it can cause heart attack, stroke or respiratory failure. Though it is a rare condition, but if it can happen and it can cause serious problem. Okay, so you have to prevent air embolism. You should not administer air bubbles to the patient. Okay, so proper priming of the IV set or the infusion set is very important. Okay guys, fine, I hope I answered the question. Then next question is, doctor advised blood transfusion for an anemic patient. Patient is already having a 20 gauge cannula on his right arm. What will you do? Okay, so here the interviewer wants to know what is your action. Whether you will give blood transfusion with the 20 gauge IV set, IV cannula, whatever he is having, or you will do something else. So please remember guys that for blood transfusion we need a large bore IV cannula. Ideally 18 gauge cannula is standardly used for blood transfusion because it has a large bore needle and there will be a proper blood flow. Okay, so whenever blood transfusion or any blood product transfusion is advised, it is always a standard protocol to put a large bore cannula, at least 18 gauge cannula. At least 18 gauge cannula, green cannula you have to put, and then you should start the transfusion, blood or blood products. Okay, and the 20 gauge cannula which the patient was having, that we can retain for giving any IV medication, because the line in which blood transfusion is going on, you should not give any other medication, because apart from NS nothing is compatible with the transfusion. Okay, at that time, so apart from NS nothing else we can give. So that's the reason you can retain the other 20 gauge cannula which he or she was having, so that we can give any other IV medications that are required, and this line should be used only for the blood transfusion. Okay, during transfusion you should not give any other things from that line. Fine. Okay, So I hope this is I answered. But one more thing you have to remember, guys, in adult patient with fragile vein or difficult vein, okay, in spite of trying you did not get any other IV access, then a smaller gauge cannula can be used, but it's very rare. But the standard protocol is to put an 18 gauge cannula for proper blood flow, for blood transfusion or blood product transfusion. Okay. Okay. The next question is, you are taking care of a patient with septic shock, okay, and the doctor has advised you to start with noradrenaline infusion, okay, because the BP is not responding to the fluid therapy, fluid resuscitation. So the doctor has advised you to start with noradrenaline infusion. So as a nurse, what is your responsibility? So as we all know that noradrenaline is a vasoconstrictor. It will help to increase blood pressure. It will constrict the blood vessel, and when the blood vessels are narrowed, more pressure is required to pass the blood. So the BP increases, heart rate also increases. Okay. So NORAD is a vasoconstrictor which will help to improve BP, but it's a high risk medication. It can cause extravasation and subsequent tissue necrosis if it is given through peripheral line. So always remember, whenever noradrenaline infusion is advised, first of all, you should have a written order from the doctor, okay, a clear order in capital letters, noradrenaline infusion, what is flow rate, okay, whether it is single strength or double strength, okay, then you will load it very carefully and you have to get it cross-checked by your senior, okay, and put an yellow label, okay, with all the dilutions properly written on it, and then you will put an EJV. You have to do an EJV cannulation for the patient. EJV is extra jugular vein cannulation. Okay, it is a quick access to the central compartment and it is easy to cannulate also because of its constant anatomy. Okay, and we have to connect this cannula to a three-way connector to avoid contamination and air embolism. Okay, we should not give NORAD infusion because it's a high risk medication through peripheral line. Okay, if it is a very very minimal dose and if you don't have an access, the patient, for example, the patient is having cervical collar is on, the patient is having cervical spinal injury, okay, or some other head and neck injuries wherein you cannot turn the patient to put an EJV, okay, and the NORAD infusion is very minimal, starting only 2 ml per hour it has been advised, or 1.5 ml it has been advised. Then what you can do is you can put peripheral 18 gauge cannula and then you can start. But otherwise whenever you have to give any high risk medication, it is always better to put a EJV cannulation, okay, and give these medications through to the main vein, okay, because it can cause extravasation if you give them peripherally. Fine. And you have to closely monitor the patient's BP also, okay. So based on that, the NORAD infusion can be tapered. You cannot abruptly stop NORAD infusion, okay. We have to monitor the BP and we have to taper it. If it was 6 ml, then they will reduce it to 4, then 2, and then stop, like that, okay. We have to taper the dose. We cannot stop it abruptly, it can cause hypotension. Fine. I hope I answered the question. Then the next question is, which IPSG goal to be followed when the patient is being shifted to appendectomy surgery? Okay, for example, you are shifting the patient for an appendectomy surgery, then which international patient safety goal you will follow? That is IPSG goal 4, ensure correct site, correct procedure and correct patient surgery. Okay, the universal protocol when you are shifting the patient for an e-surgery is marking the surgical site, a preoperative verification process, a timeout that is held immediately before the start of a procedure, and to ensure that all the relevant documents, images and studies are available and properly labeled and displayed, and to verify any required special medical technology implants are present. Okay, so all these things, this IPSG goal 4 we are following so that we can prevent avoidable surgical complications related to surgical site, related to anesthesia. Okay, though surgery is to save the patient limb or life, sometimes if we are not careful, it can cause many complications which are preventable, which are avoidable. And to prevent such complications only, we are following International Patient Safety Goal 4. Correct site, correct procedure, correct patient surgery. Fine? I hope I answered the question. Then the next question is, a patient is receiving 4 liters of oxygen through nasal cannula. What is FiO2 delivered? Okay. Oxygen therapy. So as we all know that nasal prongs or nasal cannula is a low flow oxygen device with a flow rate of 1 to 5 liters max that you can give, and FiO2 of 24 to 41%. So if you are delivering 4 liters of oxygen through nasal prongs to a patient, how will you calculate the FiO2? That is fraction of inspired oxygen. FiO2 stands for fraction of inspired oxygen. There is a formula, and the formula is 4 into oxygen in liters plus 21%. Okay, so here you are delivering 4 liters of oxygen. So it is 4 into 4 liters of oxygen plus 21. So it is total is 37. Okay, so 37% of FiO2 is delivered with 4 liters of oxygen through nasal prongs. This is how you will calculate. Please remember this formula. To calculate FiO2, it is 4 into oxygen in liters plus 21%. Okay, fine. I hope I answered the question. Then the next question is, if your patient is irritable and trying to harm himself by pulling out the tubes, what will you do? Okay, this can happen with many of the patients with head injuries or some other conditions wherein the patient is become dangerous for self or for others. Okay, they try to pull out the tubes, IV cannulas or any other tubes they are having, and it can complicate their condition. So the nurse has the authority, has the power to take the decision to apply physical restraint to the patient. They need not wait for the doctor's order. Okay, you can immediately take the help of your colleague and restrain the patient, apply physical restraint. For chemical restraints, obviously you need doctor's order, but to apply physical restraint to a patient who is trying to harm self, the nurse has the authority. Okay, you can apply physical restraint to the patient, and then you can escalate it to the doctor. You can inform the doctor, get a written order from him for the restraint, and get family consent also. Restraint policy, I think restraint, for applying restraint we need family consent. Okay, and that restraint consent is valid for 24 hours. Okay, so restraints are to immobilize the patient safely, to limit their movement, and we have to make sure that restraints we are applying in such a way that they do not cause any soft tissue or muscle or bone injury to the patient. Okay, so it is only to limit their movement. And when your patient is trying to pull out the tube, that time don't leave the patient and run for getting the physical restraint. You can take a help from your colleague, ask him or her to get the restraint, and you can apply physical pressure on the patient's body to limit their movement, and then with the help of your colleague you can apply physical restraint to the patient. Okay, so this is how you can handle the situation. So these are some of the questions, situation based questions that you may come across in an interview, and many more are there. Okay, but the video has prolonged, really it has become 49 minutes almost. Okay, so these are some of the questions that you may come across, situation based questions, scenario based questions. So you should listen to the question properly, understand what the interviewer exactly wants to know. Okay, and never speak negative about it. Okay, stay focused and stay on point to answer the question, and please use your knowledge, intelligence, experience and critical thinking skill to answer these challenging questions. Okay, so I hope this video was helpful, and if you find the content helpful, please like, share my videos and subscribe my channel, and stay healthy, keep smiling, and never stop learning. When you stop learning, you will stop growing. Okay, so never say no to learning. Always show enthusiasm in learning, may it be theory or practical. Okay, so keep learning, keep growing, be successful, and provide patient oriented care. Okay, so stay safe, stay happy, and be connected with nurses, the heart of healthcare. Thank you.